Alright, welcome to the tracheostomy lecture. A lot of this will be same stuff for you that you guys learned back in therapeutics, so hopefully we can just build upon it a little bit here. Tracheostomy, the procedure for establishing access to the trach via a neck incision. Remember, there's two separate ways to perform a tracheostomy. There's a percutaneous approach, where you do the insertion and then with a needle, and then you do a progressive set of dilation until you eventually push the trach through into the trachea. A lot of this is done with visualization under bronchoscope. Once the trach is advanced into the trachea, then we extubate the patient. Usually this is done under paralytics and conscious or heavy sedation, I should say, as well. And then there's open tracheostomy, where the surgeon will go in and they'll purposely resect different layers of the tissue to make almost a permanent stoma, if not a permanent stoma, for these patients, especially if they have throat cancer or if they have something where they're going to close off, like a total laryngectomy, and close off the upper part of the larynx altogether, or remove it. Then they might opt for a open trach versus a percutaneous trach procedure. An open trach is usually done by ENT, and they have to go in tissue by tissue by tissue and then make a permanent stoma. Sometimes they use bone and all those other things just to sort of make it a permanent stoma for those patients. So understand that a perc trach and an open trach, the big advantage with a perc trach is they tend to heal faster and less chance of infection. Perc trachs, there's a higher chance of infection because of the resecting of all the different tissue, and it's more of a permanent stoma. So you're going to have some issues with cleaning and care with both of them. However, one of them, I will say with my experience, is more prone to infection, which in my experience, it's anecdotal, that open trach usually was more prone to infection, but that will vary from facility to facility. As long as you're doing good trach care, you may not have to deal with infections very much at all. All right, there are hundreds of types and sizes and configurations of trach tubes. In Swedish, we've seen almost all of them because we have a lot of spinal cord injury and a neuro injury patient population. So that means tracheostomy. So there's cuffed, there's uncuffed, there's fenestrated, which hopefully we've gotten rid of. You see the fenestrations here on this guy. We still might see patients coming in with fenestrations. Those are those little holes that if you cap that trach, that would allow for them to have gas going through their vocal cords and they can in theory speak. But now we have those really good fun passing air valves that we can use much more effective. We don't have to worry about tissue healing in there or mucus plugs going in those little fenestrations. Also putting in and taking out, we don't have to worry near as much about that trauma part of that. There's Bavona, Portex, Shiley. There's cuffs where they're TTS, tight to shaft here, like what you see with this Bavona. You see how there's a cuff on this thing, right? You see the pilot balloon, but that cuff, when it's deflated, is tight to shaft. In other words, you don't have this loose, floppy balloon when it gets deflated hanging out in the airway, rubbing against the trachea, causing lots of secretion. So the advantage of these Bavonas is not only can they function as a cuffed tracheostomy tube, but the TTSs can also function as a uncuffed, and very well at that. You could still have a lot of gas move past it. However, over here with these cuffed ones that are not tight to shaft, what you're seeing is when these are deflated, you're still going to have some airway resistance. When it's deflated, that balloon's still going to be flopping in the airway and causing increased RAW, and therefore make it harder for them to speak with a speaking valve. So there's a lot of issues there. They even have foam cuffs, and that's why I have the foam cuff thing down there. The foam cuffs are great, and you'll see long-term patients have this, because it only uses the minimum amount of pressure needed to seal off the trachea. So if they're long-term trach patients, so a spinal cord injury is a classic example of this. If you have that type of patient, to avoid tracheal malacia and trauma over a long period of time, that might be an option for some of these patients. Some of the Bavonas over here, you'll see they even have water seal, which they say saline, but you're filling it with sterile water. The salt part can actually degrade the cuff itself. So you're actually using sterile water in those things. So you have tons of different styles and types of trachs. Intercannulas are very, very important, especially. What's the big advantage of intercannulas? Hopefully you're thinking, hey, the big advantage of an intercannula is if the trach gets plugged off, because usually these patients have thick tenacious secretions. If the intercannula gets plugged off, we can just remove the intercannula, and the trach tube itself is still in place. So all we need to do is just replace this intercannula part here, and then we'll be fine, right? So that's the big advantage of having a trach with intercannula. These Bavonas over here, these ones over on the right side of your screen, they do not have intercannula. So if they plug off, you have to decannulate and put in a different trach altogether. So it's important you know what your patient has in and what you have available at your bedside. So there's so many different parts to these. You do need to be very specific and very prepared of what could go wrong and have a plan of what you're going to do. Usually we'll have a trach the same size at the bedside and one size smaller in case their stoma, or we can't retract their stoma with the trach if we have to put it back in. For some reason, if they get decannulated, let's say they're bathing and they get decannulated or something like that, or walking down the hallway with therapy. So that's all things that we have to be prepared for and know what to do. If this person plugs off and they have a Bavona in, you can't just remove that intercannula. You have to have a plan for that. Sometimes they have these little fork-looking things. I have one of these. I always carried one in my fanny pack. Yes, you know I had a fanny pack. I still do. So these fork-looking things are awesome. They help separate the 15mm adapter from the end of the trach tube and the vent circuit. So because we're using heated humidity, sometimes I can vapor lock and connect those two pretty significantly. So this is just a little wedge that sort of pries the two apart, the circuit from the ballard from the tracheostomy tube itself, and you can also use it on an endotracheal tube as well. These things are pretty life-saving, especially if the vent's malfunctioning or if you need to bag a patient or something like that. Get that off if they're stuck together because they're just sort of vapor locked, then there you go. So one of those handy is usually pretty good. So you have the tube itself, you have the cuff, maybe if it's cuffed. You even have Jacksons, those metal trachs. Some of those Jacksons, good history question, used to be optional. They made a cuff that you could slip on there and inflate. So actually Jacksons, they used to have an option for cuffed, which is pretty crazy. A pilot balloon, of course, if they have one. There's even the high-low evac tubes, ones where it has that suction port, just like the endotracheal tubes that we talked about in the emergency airways, where it has this extra suction port that's attached up here to help relieve any of the oral secretions from micro-aspirating down past the cuff and into the airway. So it's pretty neat. Pilot balloons, maybe intercannula, maybe, like I said, with the Bavonas. Flanges are life-saving. So flanges are these little things, these little wings that go out, and they prevent the trach from going in further. Sometimes you have an adjustable flange, sometimes it's set. This one has an adjustable flange. You can see here, you just unclasp this thing here on the blue one, and you can move the flange further out or further in, depending on the patient's anatomy. So you have adjustable flange trachs. A lot of trachs are set. You can have an extra long trach too, where it's extra long forward and aft, or you can have an extra long where it's up and down, right? So it depends on the patient's anatomy. If they have a tracheomalacia, we might have to get one that's a little bit longer up and down vertically in that y-axis, just to help go past that tracheomalacia part if they're dependent on having that cuffed up. Obturators are a must. That's this guy over here, down here. An obturator is a must. You need an obturator at the bedside, especially with trachs less than 2 weeks old. So if they're putting in trachs, whether they're open trach or a perc trach, you need that obturator at the bedside, at the ventilator bedside. That is a requirement, because if that trach becomes decannulated and it's less than 2 weeks since the placement of that trach, there's a very high likelihood that that stoma, you may mistrack it. It may not be able to put it in, so that significantly reduces the trauma to retracking or putting a trach back through a stoma site. Those can close off fairly quickly, especially perc trachs, within the first 2 weeks of the procedure. So they're very, very tenuous. You need that obturator usually within those first 2 weeks. It's also very gentle. Let's say they've had their trach in for 3 years and you're doing a trach change, right? Putting that new trach in with that obturator really helps reduce that chance of tearing any of the lateral walls of their airway as you're reinserting that trach back in. So obturators are a must. Obviously, these are all 15 millimeter universal adapter, but those flanges, always secure those flanges very, very well. Other parts and pieces, you're going to have these adjustable parts here that you can attach the vent circuit and the trach together, and it's going to allow for a lot less torsion and twisting on the trach. Obviously, that can be bad. Pressure dressings, especially if there's a lot of bleeding, can go on. These wedges are life-saving here, these little wedges over here. So that's that disconnect wedge, and that really can pry them off and allow you to do some good ventilation therapy if the ventilator fails or whatever machine they're on is failing. Of course, you got to be very careful with their skin and pressure sores. That's why usually we'll put that 4x4 gauze back there. That's that split dressing. So the same thing they use for G-tube, that wound ostomy, G-tube ostomy drain gauze sponge. Well, same thing here. Sometimes you'll see trach ties, and that's these things, these Velcro things. Trach ties can get very bloody, very nasty. They need to be changed on a regular basis. A lot of the fresh trachs, especially the perc trachs, are sutured in for those first 2 weeks. And so even at Swedish, and it depends on your facility, we would have to go in and cut the sutures, and we had special permission to do this. This is something we clarified with the physicians before we do it, to cut and remove the sutures and then go ahead and change the ties. So I would change the ties first, then cut and remove the sutures. So that way I knew it wouldn't come out no matter what, because it was still sutured in. And then we could put the trach ties on. These can get nasty and gross and secretions and wet, and you're asking for skin breakdown if you do not change those things out. And then obviously they have these really cool metal ones here. Those are more for your long-term care patients. You may not see too many of those in the hospital unless you're working ER and someone comes in. Those are more home care style long-term patients, so we'll have those in. But yeah, you're going to have these trach ties that will help keep things together. We even have what's called a stronghold, and if there's a ventilator circuit attached to the tube here, it's just this little Velcro piece that straps from flange to flange, and it helps secure that circuit. So that way if the patient coughs, they won't cough off and pop off the ventilator circuit. So we even have those to play with as well. So the flange is going to be one of your biggest keys to knowing what's in a patient, especially if you're working ER and a patient comes in, it's already trached, you don't know what they have. The size and the type of the trach should be on the flange. Sometimes it's easy to see, like you see up here with this trach, but when you're down here, some of these, they're just trying to challenge you. They're just trying to see what type of day you're going to have, trying to figure out what's in there. Now, of course, they're trying to do it for aesthetic purposes. However, you're going to have to make sure you're carrying your readers that day. Just kidding. I always had a magnifying card in my fanny pack. Woohoo! That magnifying card comes in pretty handy, especially if you're trying to look at something like this or EKG paper. So those little wallet magnifying cards, or those like credit card style magnifying cards, came in pretty handy. Plus you can buy a pack of them and they're pretty disposable if you need to. So if a person comes in with a bad trach, you don't know what type and size it is, just look at their trach flange. It should have that information on there. Sometimes people are cuffed during the day, or sorry, not cuffed, capped during the day, and sometimes they're not. So if they need a cap, that's something that we should have available to them. Of course, before you cap a trach or put a passing mirror valve on, always make sure it's either a cuffless trach or that the cuff is fully deflated. Otherwise, you'll find out pretty quickly that that works as a great lung recruitment maneuver, but not as a life-sustaining maneuver. They can breathe in, but they can't breathe out. Indications for tracheostomy: overcoming an airway obstruction, especially tumors, traumas to the upper airway, especially if they can't get an endotracheal tube in, but they might have reserve enough to put a trach in instead of criking a patient. Long-term vented patients, for an adult, usually within that 2-week period, they'll wait at least 14 days around that area. Sometimes sooner if we know they're a neuro patient or a spinal cord injury patient, we might do it sooner on just to get them off, because that might be the only thing keeping them on the ventilator. Because they don't have any neuroprotective responses, then the trach is all that they are needing to be on the vent for. So the earlier we do it, the earlier we get them off the vent. So it sort of is variable. Now, kids, if you're working in a PICU, kids usually they'll wait forever, like way past 4 weeks, 3 to 4 weeks, before they would ever even consider a tracheostomy on a kid. So pediatrics, a little bit different ball game, but adults usually around that 2-week mark is when they're considering either doing a trial extubation or a tracheostomy maneuver. So that'd be your long-term ventilation. Airway care for patients with neuromuscular. These are your ALS, SMAs, those type of neuromuscular spinal cord injury patients. Those are going to be some of your big ones that they'll put a tracheostomy tube in as well, because they can't protect their airway or they're having issues with their swallow gag protective mechanisms. So that's why they'll go ahead and be a good indication for tracheostomy initially, until they can develop their muscles or get something there. Failure to wean. It might be easier to wean a patient with a trach as opposed to an endotracheal tube, because over here we're going to pretend this is our very long endotracheal tube, and over here we have a tracheostomy tube. According to Posey's law, the longer the tube, not just the airway resistance related to the diameter, but let's say both of these tubes have the same diameter. Well, because this one is shorter, the tracheostomy tube is shorter, and it has less dead space, and it's also shorter, and that means we're going to have less airway resistance. The shorter the tube, the less air resistance. You can try this, right? Try breathing through a coffee stirrer, right? You cut it short, it's not going to be near as hard to breathe through it because you reduce the length. So there's less dead space and you reduce the length. So according to Posey's law, it might actually be easier to wean a patient off of a ventilator with a tracheostomy tube than with an endotracheal tube. The other advantage here is we can use T-piece weans, which you can use with an ET tube, but you can use T-piece weans, and you can also disconnect them from the vent all together, right? They can do spontaneous trials that are true spontaneous, where we're just using heated aerosol as well, which the psychological factor of not having a ventilator circuit attached to the patient is a big bonus, because now they don't have to have near as much sedation. We can always reconnect them if we need to. We can keep them off during the day and then vent them overnight. There's a lot of advantages here with going to a tracheostomy tube. So that's why it might be easier to wean a patient with a trach as opposed to ET tube. So first answer, physics, right? Science. And then the second answer is psychologically, like it can make a big difference as well. And we know we have that support where we could just reattach them if we need to, and otherwise they can be off. They can talk. We don't have to worry about intubation and sedation. They can be almost fully aware all the time. So we don't have to worry about something called ICU delirium, where we're using too much sedation. So ICU delirium is something for you guys to look up, and we'll talk about. Needle cric, we talked about this in the emergency airway chapter or emergency airway presentation. These are last resorts only. I only seen less than a handful of these, probably about 3 my whole career, in bedside practice. Obviously they're more common than that out there, but these are high risk of cutting other structures that are around there. Hey, you got, the carotid and the jugular veins, the carotid arteries and jugular veins that are running along the trachea. There's a lot of other things that are going along in this area, and so a tracheostomy tube procedure like perc trach is definitely going to be a lot safer than a needle cric, and you're going to have a lot more effective ventilation. And ultimately, if you're going to needle cric someone, either they're going to have to go back and still get intubated orally, or they're going to have to go get a trach put in place anyway. So a lot of times our trauma team would just go ahead and put in a quick perk trach at the bedside, so you should be ready for that procedure, especially if you work at a level 1 trauma center. So these are emergencies. You can ventilate and oxygenate somewhat. It's better than not having an airway for sure. But if the patient's relatively stably unstable, I don't know if that makes sense to you, but if they're stably unstable, in other words, they're hanging in there, they're unstable, but they're hanging in there, they might go ahead and just put a perk trach, do a percutaneous tracheostomy approach versus doing a needle cricothyrotomy. All right, so these videos are good for you to watch. I can't watch them through with you, but hey, I strongly suggest that you watch these. They are good videos to sort of see what's going on. Non-emergency tracheostomies, usually, like I was talking about, 14 days is when they start to consider this. Now, it can be earlier in some different patient populations, like I was saying, neuro, spinal cord injury patient populations, so on. Each hospital will have its own guideline and culture on this sort of situation. However, all the evidence out there that I'm aware of, and I'm always willing to be wrong, and hopefully one day, like, the evidence will be updated, and this information will be too. But as of currently, I'm not aware of any evidence that says doing it any sooner than 14 days on the average patient population. Now, I'm not talking about spinal cord injuries and so on and so forth. Just 14 days would be when you would consider. So you give them that 2-week buffer to try to get extubated and fly. The traching early and traching often has not shown any benefits of long-term outcomes, days in the ICU, days on mechanical ventilation. It's not been shown as far as evidence or statistical significance to have any improvements in the long term for these patients. That's why after 14 days, that's when they're like, okay, this is more of a long-term issue. Let's go ahead and move to tracheostomy if it's indicated on this person. The idea here too is we need to wait till the acute phase of this patient ventilation period is over. So mechanical ventilation has sort of 3 periods. You have your unstable, that's why they're getting intubated and put on mechanical ventilation. Your stabilization phase, where we're steadily getting this person healthy and into a stable health state. And then there's liberation. That's okay, now they've recovered from whatever they were unstable from. They've recovered from whatever that caused them to go on the ventilator, and now we need to liberate them from the mechanical ventilator. So that's that weaning to extubate phase. So we need to wait till both those first 2 phases of mechanical ventilation, the initiation and the stabilization, we need to wait till those 2 phases are over, and then we can consider something like a tracheostomy, because you don't want to be unstable and then performing a tracheostomy and you're not able to get the tracheostomy tube in, and now you have a patient that's gone through the trauma of a surgical procedure and they already had poor oxygen requirements to begin with, or so on and so forth. And it could be enough to push them over into the really bad side of their health care altogether. So we need to make sure their acute phase is over. So let's say it's been 14 days. Let's say this person has severe ARDS and they're on 80% oxygen and 14 of PEEP or CPAP, right? That's a lot of pressure and that's a lot of FiO2. Is this person stable enough for a tracheostomy tube? In general, no, right? We're going to have to wait further. So we need to make sure they're stable for this procedure in this non-emergent state, right? Considerations. How long will the patient need the airway? So is this a person we're going to remove part of their upper trachea and we'll make a permanent stoma because they have throat cancer or a tumor that's pushing on their throat, right? So maybe they're more of a open trach procedure, and so we need to look at that. How long will they need the airway? Is this going to be someone that's going to be intubated for 3 or 4 days post a car accident, or is this going to be someone that was intubated maybe a couple weeks to a month or 2 months? Then that might be a consideration for let's go ahead and do a trach sooner than later, especially if it's a spinal cord injury or neuro patient or severe stroke victim, things like that, because they just are failing to protect their airway, but they can breathe fine otherwise, then that's a good person that we can trach early, get them off the vent early, and avoid side effects of mechanical ventilation, which are numerous. Tolerating the ET tube, especially, we have to use heavier sedation for ET tubes versus trachs. Of course, you don't have to worry about a trach person biting down on their tube, unless they sort of lose dentures and it goes down into their... Don't worry about it. You don't have to worry about them biting down. The tolerance of the tube is much better with a trach versus an endotracheal tube. Their medical conditions, are they healthy enough to get a tracheostomy tube, or are they not? Can the patient tolerate the surgical procedure? What's their FiO2 and PEEP? What's their oxygen concentration requirement, and what's their x-rays trending? What are their labs running? Are they in the middle of fighting a massive infection currently? If they are, then we are probably not going to trach that patient yet. They'll be on the list, they just won't be next on the list. So the risks might outweigh the benefits of a trach, especially if they're on 100% oxygen and 20 of pressure, right? They might have more risks associated with it, especially if their body's already fighting an infection. You give them a tracheostomy procedure that makes them prone to infection. That could be the tipping hat for this patient's overall condition. So we got to be careful about our risk versus benefits in every single medical situation, not just with tracheostomy tubes. Bedside procedure is usually your percutaneous tracheostomy. So we would do these in the ICU. Hopefully some of you went to the Swedish or a place where they did bedside perc trachs and got to watch it. The bedside is great placed. We'd put the bronch in, they would do the needle, then we would go ahead and do the progressive dilation and put that trach in. So usually the perc trach's the bedside procedure. We don't have to take them, transport them, get them exposed to different areas. Going to the OR is usually where your open trachs are. If we have a very difficult trach to do, we'll do it in the OR with anesthesia, and then we might actually use general anesthesia obviously with paralytics on both of these procedures, but we might have to go to the OR for sure. So bedside procedure is going to be one of those things we have to look at. The tracheostomy tube advantages, we can avoid a lot of laryngeal complications, vocal cord injuries, things like that. It can be a lot more comfortable, especially long term, so we don't have to use near as much sedation and worry about them biting on the tube and all that stuff. They can still eat, swallow, do oral care, all that stuff. As long as that cuff's deflated, they can do those things. So right, that's not something we put the trach in at 3 o'clock in the afternoon and at 9 o'clock at night they're eating lunch, right? That's not a typical progression currently. So that's down the road. We can deflate their cuff and we can have them start to do all those things. We can bronch a lot easier through a tracheostomy tube. We don't have to worry about going through a nose. We don't have to worry about a bite block going through their mouth and biting on the tube. It's a lot more tolerable, easier to bronch for sure. Reinsertion, if they get decannulated, usually there's that open hole we can just reinsert. We can wean off the ventilator a lot easier. We already talked about that. You don't have to worry about main stemming as much. It's not something that can't be done, especially if you have an XLT, an extra long trach. They could put it in too far, and that could easily go into one main stem versus the other, and that can be a big issue. People won't really recognize that early on. However, I have seen it in practice. And in fact, the person that we've seen it on, they developed a pneumothorax and they didn't even know why. And we looked at the x-ray and sure enough, the trach was an XLT, it was an extra long trach, and it was main stemmed. So that was something that we have to be very careful of. Decreases worker breathing rate because of Posey's law, saying that the shorter the tube, the easier it is, or the less air resistance will be created. These are usually a lot more stable, a lot less chance for it to be pulled out or pushed in. It's a lot less chance of that overall going on. It's usually in between the first and second or second and third tracheal ring, depending on the reading source that you're looking at as far as where the trach goes in the actual anatomical position. These are great for long-term people out of the ICU. Ultimately, these can go to skilled nursing facilities, so on and so forth. Disadvantages, there's a lot of cost associated with the procedure and the equipment and DME, home care. Family needs to be trained, home care nurses, home care RTs. so on and so forth. So there's a lot more costs for long-term. It is an invasive surgical procedure. There are inherent risks, right? We do have to paralyze. We do have to use sedation, heavy sedation. There's severe complications. They could always, especially with the tracheostomy tube, there's something you got to worry about is the TIF, tracheal innominate fistula, where that cuff over time on these long-term trachs can actually wear away on the inside of the trachea itself, and actually might wear into the innominate artery. Google it, the innominate artery, which is sort of connected to the carotid artery, which means they're going to lose blood, and both those come off the aortic arch. And so they're going to lose blood very fast. They'll bleed out into the lungs very fast. It's very rapid and bloody demise. It's a very, very bad thing. So tracheal innominate fistulas, well, this could even happen during a trach procedure where they could nick the innominate artery. I've seen it, unfortunately. That patient did survive, but that's something that can happen. Increased mortality rates usually due to infections. You're bypassing the upper airway, which is a protection mechanism. So when you bypass the upper airway and the protection mechanism, it usually leads to a higher chance for infections like pneumonia. So the earlier that patient can be decannulated down the road and they don't meet the requirements or the needs for a trach anymore, the sooner we can get that out, the better, because that keeps them off of the chance of having a giant mucus plug and going into a code or developing a pneumonia because they're bypassing all their upper airway protection mechanisms. So they're just very, very prone to a lot of things. So that's what that increased mortality rate is all for. Complications, tracheomalacia, that's where it gets all loose and floppy because the cuff's inflated too much. Boo. That's why we have the cuffless trachs, TTSs, so on and so forth. Tracheal stenosis, where it gets really stiff. It's not uncommon to see these tracheomalacia and tracheal stenosis where it narrows down. Some have to go in and put a stent, things like that. There's a lot of stuff. They can also form granulomas as well, especially more with the old school fenestrated trachs. Hopefully you're not seeing much of those anymore, but if you do, they're more likely to form granulomas. And finally, fistulas. That's what I was talking about earlier, where the TIF, tracheal innominate fistula, that's one of the things that you've got to be worried about. If you do see a TIF, hyperinflate that cuff or put your finger in the stoma and hold pressure. That person needs something fast. So fistulas can be a thing. TE fistulas in theory could happen. I've never actually seen it go through the trachealis muscle in the TE fistula, but something to be aware of. Complications. Preventing movement is going to be one of the big things, especially within that first 2 weeks after a fresh trach, because it can push and cause tearing and trauma on that fresh surgical wound that was just created. Make sure you're using the correct size. You're not going to put an 8.5 in grandma, right? In little 5'2" grandma. Like, that's not something that's appropriate. So that can cause a lot of complications where we may not be able to pass a mirror or cap or anything like that. So we need to use the right size for the right patients. Measure cuff pressures. Notice that's all underlined here. Measure the cuff pressures. We actually have to chart that unless they're uncuffed, and then we still have to chart that they're uncuffed. So the idea here is to avoid obviously tracheal damage by making sure the cuff pressures that we're using are minimal to what we need to do. We need to make sure we're using humidification because we're bypassing the upper airway. Now we have to use whatever device they're on, whether it's a heated trach collar, a BiPAP, like in AVAPs or anything like that, or heated high flow or anything like that that we're doing to the tracheostomy tube itself. It needs to have as much humidification as possible. Otherwise, they will dry out their secretions and mucus plugging will be an issue for these patients. And we need to clean these trachs regularly. We have to do trach checks Q6 at Swedish pretty regularly to make sure it's clean. We'd have to chart the skin integrity. It's a whole big thing. So clean it regularly. That'll avoid a lot of skin breakdown and a lot of infections as well. Tracheostomy procedure. So this is the thyroid cartilage here. This is the cricoid cartilage here. This is the cricothyroid membrane. In between the two, that's where a needle cricothyrotomy would go. And here you see first ring, first tracheal ring, second tracheal ring, and then between the second and third tracheal ring is usually where the trach is placed. So traditionally between the second and third tracheal ring. Now let's say someone has a very short neck where their clavicles, like just say anatomically, their clavicles and the lower part of their jaw are very close together. They might do first and second, but usually it's in between that second and third. So that would be cricoid 1, 2, 3. So that's what we're looking at here. Effective for emergent, elective or emergent is what we're looking at for the two primary issues or primary reasons why we might be putting on. Is an elective issue why we're putting it in, or is it an emergent issue why we're putting it in? Remember, there's two types of procedures, percutaneous and open. Now these are just elective and emergent. So usually you're going to have a skilled physician. You do not want your podiatrist that's doing rotation just to keep up their hospital skills to be doing this, right? Someone that has skill in doing this procedure. And I'm not saying a podiatrist couldn't, but let's just make sure that someone has gone down this road before. It's a very sensitive situation. So the two main planned procedures are going to be your open trach or your surgical trach, or your percutaneous. The open trach is usually done in the operating room by ENT, ear, nose, throat, otorhinolaryngologist, or percutaneous. Our hospital had trauma do percutaneous. Our intensivists could do it as well, but they didn't have near as much practice as our trauma surgeons, and so we use our trauma team to do that. Surgical or open trachs, aka incision at first, between the first and second, or the second and third tracheal ring to expose the tissue. The tissue is dissected, and they go through the next tissue, resect that, so on and so forth, until they eventually just insert the tracheostomy tube. Please watch these videos. Surgical trachs, the advantage of a surgical trach, and that's what we're talking about here. Don't you love these pictures? Less chance of unintentional damage to other structures because we're going through very calculated way and identifying the structures and going through them instead of just progressively dilating a hole that we punched into the trachea with the perc trach, right? So a lot more identification of the structures, better for more complex cases, like I said, people that have throat cancers, or we're doing a laryngectomies, things like that. Almost always done in the OR. It's very rare it's done outside the OR. Disadvantages: wound care and healing is very messy, very, very messy. As you can see here with this patient with the Jackson, that is an open trach that got infected and necrotized, and it's bad. And that was my experience too, and it's something where they would come out and our ENTs, were very open about how higher chance of infection and nasty and how bad they would heal. That's why we were big fans of trachs. Percutaneous, that's this one. We're going to hyperinflate the ET tube cuff, and we're actually going to pull back until the cuff is against the vocal cords. So we hyperinflate the cuff to help prevent accidental extubation. We got to create room in the trachea for the tracheostomy tube while this person is still paralyzed and on the ventilator. So we have to paralyze them because we don't want them moving around or we're cutting a hole in their neck. That would be a very dangerous situation if we didn't. So we pull the tube back and it sits against the vocal cords. We're going to insert the bronchoscope and we're going to transilluminate the trachea. So that means we're going to use the light on the end of the bronchoscope, and we're going to see from the outside, the surgeon will see from the outside the light of the bronchoscope, and then they sort of know where to insert that needle, that initial needle. So they'll stab with a needle that has a little bit of saline in it. And look for bubbles. Bubbles means they're in the trachea. If there's no bubbles, they may have stabbed something wrong. So once they're in the trachea, they'll put a guide wire in there. All right, they'll take the needle out, and then they'll progressively dilate that wound until they slide the ET tube, or not the ET tube, the tracheostomy tube over. So let me ask you this. Let's say you walk into a room, a person's trach has been coughed out, whether it was an open trach or a perc trach, you are unable to get it to track back in. That person is dependent upon that trach tube. What would you do, right? And let's say you did not have a spare trach at the bedside. Well, first of all, very shame on you for not having a spare trach at the bedside. And second of all, shame on you for not having a spare trach at the bedside. And I hope you remember that. Third of all, an ET tube would work if in this situation there. You could put the ET tube, a small 6.5 ET tube, you could put through the stoma if you somehow lost or damaged the trach that this person was dependent on. Put that ET tube in through the stoma into the trachea. Make sure you verify with end-tidal CO2, right? Qualitative, quantitative, whatever you have available, and you're able to ventilate, right? All that good stuff. And it just sticks out of the neck very long. So it's very important you understand how to troubleshoot these airways. In theory, you could use an ET tube, a small ET tube as well, just to hold you over until you're able to relocate the spare trach, which shame on you, you did not have at the bedside. All right, advantages of the percutaneous trach: fewer stoma complications, a lot less issues with infection and wound care, improved neck anatomy. In other words, we don't have to worry about near as much lateral or trauma around the wound itself. We have just that sort of wound itself just right around the trach, but nothing else was resected or pulled, so we don't have as much anatomy involved in the surgical airway. It's best cosmetic when, if we decannulate down the road, if we don't think this person's a permanent trach person. Perc trach is best for that because that stoma can close and heal very well, where it's just a small little scar. Very, very well compared to an open trach. Disadvantages: these are a lot more difficult to change because the stoma is much smaller, it's a lot less permanent. That makes it high risk initially, especially for those first 2 weeks. That's why we usually sutured them in and left those sutures in for the first 2 weeks. Now, our policy at Swedish was we had to have the physician do the first trach change. I will tell you, well, this is going to go public, so I will tell you that is the policy, and we always abided by that policy. So high risk for damage to structures when inserting because you're not identifying the airway, in theory, the different airway structures individually as you go through. Maturity: can take several weeks for a stoma to mature and become stable. Immature stomas, they can close very quickly, especially if the trach is dislodged. That's why we would suture them in for those first 2 weeks with our perc trachs especially. Open trachs we weren't worried about near as much. Further away from the placement date, the more mature the tract will become, so more permanent it sort of is. Infections will delay maturity, especially with open trachs. It's going to take a long time for those to mature. Tracheostomy, the tube size should occupy about 2/3 to about 3/4 of the internal of the trachea. So that's, once again, you using the right size. If you use too big of a size, like we talked about, if you're using an 8.0, if you're using too big of a size on grandma, a 5'2" female, you're going to have a lot of issues because they're not going to be able to wean or step down the size of their trachea very easily. So 2/3 to 3/4 of the internal of the trachea. Different manufacturers have different measuring systems, so know that a 6.5 Portex and a 6.5 Shiley and a 6.5 Jackson, so on and so forth, they are not all equal to each other. Isn't that a blessing, right? Job security. So we usually have a conversion chart in the hospital. In one of the equipment rooms, you'll probably see conversion charts that sort of tell you what is the equivalent size. So if we want to move from a Portex to a Bavona, TTS Bavona, then that's something that we have to look up that on that chart to see what size would be equivalent. So Portex, Bavona, and Shiley are usually some of the more common hospital ones that you'll see out there. The Jacksons are more of your long-term, the metal ones. Long-term ones, I loved the Jacksons for your long-term patients. These are great because they're metal, and the reason why I like that is your airway, your mucosal airway, when it does rub against the airway, right, just like when they do a hip replacement and all those other things, when they're putting metal in the human body doesn't read metal as a foreign object as far as that stuff is concerned. When you're putting it on bone or drilling through, like putting screws into a hand or something like that, like it doesn't cause the inflammatory response. When you have plastic that's constantly irritating, rubbing the airways, the body sees it as something foreign and creates what's called biofilm. And biofilm is what, if you pour a bunch of saline down a trach, you're washing it into their lungs, causing a chance for a big pneumonia. So I loved the Jacksons. Usually these people have a lot less secretions going on whenever we switch them to a Jackson. Intercannulas, these are the safety net of trachs, right? This is where we put the intercannula in. If there's a mucus plug, we can just pull the intercannula out, replace it with another intercannula. We don't have to worry about pulling the entire trach out and decannulating and putting a new one in like you would have to do with a Bavona. Bavona is you don't have that intercannula, you don't have that option, right? So the primary role of the intercannula is to allow us to be able to clean the inner surface of the airway. All right, not all ones have intercannulas, especially the one that comes to my mind is Bavonas for the most part, right? You must use an intercannula unless a physician orders otherwise. That's something that we always had in place. Like and some physicians would not want intercannulas. You're like, why would you not want an intercannula? Well, what happens to the internal diameter of the airway? According to Posey's law, if you put an intercannula in, the internal diameter of the airway gets smaller, which means there's more airway resistance. So some physicians actually told us and would write an order, do not put an intercannula in this patient. So there was slight advantage to that. So just understand what's going on, why they're doing that. But if you have the ability to use it, I would err in the side of using an intercannula and then talk with the care team if you think that that's enough air resistance, or that's something that I would clarify later. But intercannulas are a must unless otherwise ordered, or unless you have a trach that does not have that option, right? Especially with mucus plugging, that's going to be your big thing. The two basic types of intercannulas, there's disposables and non-disposables. Intercannulas, even with Jackson's has a metal intercannula that it uses, so obviously that's a non-disposable, right? They're going to have to be cleaned. The non-disposable are more durable. They can use for your long-term home care trachs, and that's why someone comes in with a home care trach and their intercannula. That's something that you might have to keep and actually clean and be a part of that, depending on the hospital policy and procedure. Disposable Shileys have an opaque 15mm adapter that has like this turn lock on it, and that's this guy here on your left. And there's this turn lock where this locks into that part of the trach there, and so if the person turns and the vent circuit sort of catches them odd, or they're on a T-piece and it catches them odd, you might see this trach pop out like you have in this picture, where the intercannula is sticking out of the trach, and they're going to be losing pressure and oxygen and all that stuff. So that's not a very good thing. Disposable ones are ones that we usually use in the hospital, right? This is a nice little Shiley over here, and this sort of clicks in, right? And hopefully you guys have played with the trachs in therapeutics or in the hospitals already. I like this one a lot, but even this one still, if someone doesn't click it in all the way, or they just push it in there, it can still pop out like you see over here on this Portex, and you're going to, Shileys, you can see it pop out, and you'll still have sort of the same issue. So either one of these can pop out like that you see on the left there. And it's a very dangerous thing. You might lose some oxygen and air and seem to saturate and stuff. So it can be dangerous. Now, in clinicals, I had a patient that was on that was trached. They put in intercannula. They changed the intercannula that was on the vent, and they changed the intercannula, and the intercannula was for a smaller size trach, still clicked in. And so the patient was losing oxygen. They thought the cuff was blown. They thought all this stuff. And I asked them, I'm like, what size is the trach? And they were like, well, it's this size. And I'm like, well, what size was that intercannula? They said, well, no, it's the right size intercannula. And we looked in the trash can. We didn't grab at it, but we looked in the trash can. Sure enough, the intercannula was for one size smaller. And so we were losing gas pressure and all that stuff around that. So something to be aware of. So some trachs are designed without intercannulas, silicone and stainless medical grade steel ones, right? That's what you're looking at with the Bavonas and the Jacksons. The big thing here is the mucus is a lot less likely to stick on these surfaces and cause a mucus plug. So like we were talking about with the Jackson trachs, not only would the airway like this a lot more, but they're a lot less likely to have mucus sort of stick and collect on there compared to your normal PVC. That silicone, that Bavona is just my big example of that we would use. wouldn't have as much ability to have the secretion stick and create a plug. So you're less likely to need that inner cannula part there. In theory, we didn't have too many issues, but we were really good about humidity for the most part, and even pediatric trachs, and that's what you see over here. We have some tiny ones in the lab too. Humidifications. Most people will need this humidification for sure. If they're capped during the day, do they need humidity? Absolutely not. So that's what we're looking at. So if they're dependent upon it, then yeah, they're going to need that humidity. So bypassing upper airway, which is a humidification system, we need to humidify it if they're dependent upon that airway. Most of their gas is going through the trach tube. We need to make sure it's going through the trach tube humidified. And so dry gas can thicken secretions, which puts it more likely to plug off. Cool air will decrease ciliary function, which means their ability to clear the secretions gets worse. Not only that, the ability to clear the secretions gets worse, and their secretions get thicker and stickier. So you're asking for a mucus plug code situation here. So if you want to give them gas, you want to give them warm and humidified gas, right? That's the big thing. Humidity devices, we can use little trach HMEs if they're getting up to walk around. You'll see these in long-term care patients where they just have the oxygen attached to a little HME there that allows them to walk around King Supers or wherever to keep humidified in the hospital. Obviously, large heated humidifiers, these are more like your trach collars and T-pieces. Heated high flows, those are humidified, of course, heated and humidified. Those are great for helping to wean patients off a ventilator. They might take them off the vent and put them on a heated high flow connected to the trach, and that's actually been shown to help them get off. A large jet humidifier, something that gives them lots of good humidity overall, is something that we can look at. T-pieces, if someone has lots and lots of secretions, I loved a T-piece because then you have this ballard that you could go into suction with. You didn't have to worry about doing the whole sterile procedure and clean technique for the suctioning. Trach care must be done at least once a day in general. We would do it Q shift and as needed. Make sure you check your equipment. You're telling the patient what you're doing. That goes for everything. Doing a blood gas, tell them what you're doing, right? Suctioning the patient, tell them that you hear some mucus in there. You're going to try to help get it out with them, right? Cleaning, make sure you keep the stoma site clean as well. Don't be one of those lazy therapists that says, yeah, I cleaned it and charred it, and then you go in, the person on the next shift goes in and it's just crusted up and yeah, looks terrible, and now their skin's starting to break down. If that was your loved one, you would be very upset with that. Replacing your cannula, like all this is going to be per your facilities. Make sure you chart everything. Trach care, remember hydrogen peroxide is a mild acid. If it's used to clean the stoma, it can actually make the wound worse. So they used to recommend a 50% concentration of hydrogen peroxide, and there was a journal, I think it was a nursing journal, that came out with that study, and maybe someone will look it up for me for bonus points. There was a study that showed it was actually bad for stoma and wound and skin, and so they recommended just using sterile saline. Right? Or sterile water. If the stoma is getting nasty, more frequent care might be needed. But we stopped using hydrogen peroxide on all of our stomas. So, big no-no to hydrogen peroxide at Swedish Medical Center. Unless something changes out there, that's something that we had to move away from because the evidence said don't do it anymore. Usually the sutures, and you'll see them here in this picture on the left, the sutures are going to be your big thing to help keep that trach in for those first 2 weeks. Sutures can usually be removed after about a week, but some docs like them to stay in longer. Our facility, usually about 2 weeks, unless they were getting red and irritated and looking infected, then we might get those removed sooner than later. As far as trach dressing, light and air may be the enemy of most bacteria. So the big thing here, there's going to be, and I always consulted with wound care nurses and all that stuff too, because we would try to figure out the best situation for their skin behind there, and I wasn't taught skin, right? That's not something that we're experts in. So I would go to the expertise of the wound care nurse there. Dressings tend to get wet, hold moisture, mucosa, especially on trach collars, so that could be a breeding ground for an infection. So that's something we got to look at. There's even the spray. You guys can look this up on your own, that they can spray the backside of the skin of the stoma, and it actually repels. It's like a hydrophobic spray, and it actually repels secretions, repels all that stuff back there. So it's pretty cool stuff. So there's a lot of different things here about wound care dressing and stoma dressing. So that's something that we got to communicate. What are we doing with the dressings? What does the surgical site look like, right? Is it look nasty? Does it look infected? Does it look red? Is the skin looking red? That's all bad things. So the dressing itself can cause irritation. So we need to do something. All right, pressure ulcers are a bad thing. That's why I put all these gross pictures. Hopefully you get that negative connotation with pressure ulcers. Every neck is different. Short necks, bigger chubby toddlers, those little chubbers, bariatrics, I love those little guys, can have necrosis or granulomas easily develop. So the big thing here is catching this early, doing your trach care, watching things, charting it. If you see something weird, get the nurse, get the wound care, talk to the physician, have them look at it, right? You might be the only one really taking a detailed look at it. And I'm just not saying that anybody else shouldn't be, but you might be the eyes that catch this early. Changing into the trach, this is a big procedure altogether because you're going to have the patient usually assemble all the equipment. Always made sure there was a neonate ambu mask so we could bag through the stoma, especially if they were a laryngectomy patient. Then you can, in theory, still ventilate and bag and seal off that stoma as well. Explain the procedures to the patient that you're just going to take their old trach out, put a new one in. Make sure you have all of your equipment, prepare the patient. Make sure you always have someone else in the room. I always would call my charge therapist or have the nurse or someone else in there. Remove the old trach. Remember, you're going to remove it in a curved fashion. You're not going to pull it straight out. You're going to curve it towards the sternum. Insert the new trach and secure the trach tube. And then reassess the patient. Is it in the airway? Did they cough up secretions through it, right? Was there end tidal? So on and so forth. So this can be actually a very traumatic procedure, especially if it's their first trach change. But we can play with this in the lab, and I hope we do get a chance to. First trach change is usually 2 weeks after the procedure. It can vary widely from facility to facility. As far as the evidence goes, that first 2 weeks is pretty common out there. Almost always done by a doctor, and since this is going to be public, I will say there you go. Subsequent changes might be the RT or nurse or family at home care, during home care, right? That's something I might do at home, and hopefully we'll go over this in more detail. I will not confirm or deny if I was part of that. All right, trach care. Communicating with the trach patient can be difficult. This is why I love passing mirrors, note writing, message boards, all these things, and it's just frustrating for them because they have to work to communicate, and it's a big issue. And they try to mouth words. I was lucky enough to play baseball a lot, and stealing, mouthing words and all that stuff was something that I had to do. But the number one complaint of a trach patient is I can't talk, I can't communicate, I can't talk to my family, I can't tell people what I need, what I don't want. So it's a big thing. And kids, and that's why we're so hesitant to trach kids, is because their development of their speech and everything down the road can be greatly affected, including putting a scar on their neck, can be greatly affected. And so that's why kids, we'll wait a month plus before we ever start traching a kid. PMVs, I love these guys, especially when you can connect them to a ventilator. Hopefully you guys will go through that IMV, connecting a passing mirror valve to a ventilator so the patient can talk while they're on the ventilator. Christopher Reeve was a classic person about this, where he had a diaphragmatic pacer so he could live and breathe without his ventilator, but his voice was soft because he had a diaphragmatic pacer. And so whenever he was being interviewed for news or doing a speaking engagement, he put himself on the ventilator with the passing mirror so he could speak. So it's very cool. Different configurations. They even come with these little oxygen adapters so you can hook oxygen up. And so here you see this purple one up here, and it has that little adapter sitting out of that side there, and that little adapter you can put on there so they can physical therapy can walk them up and down the hallway, and they have some oxygen going to that. Obviously, make sure their cuff is either deflated or they're cuffless. Otherwise, you will learn pretty quickly. Great lung recruitment maneuver because they can breathe in, but they can't breathe out. So make sure the cuff's deflated or they have a cuffless in anytime you do that. My classic case, I had a patient respiratory wheezing. The nurse called me and said, "You need to come quick." I came quick, and they had put the Passamir on. They didn't deflate the cuff, and he didn't have any atelectasis on his X-ray, that's for sure. Weaning trach tube patients who wean trachs patients who have trachs often have been intubated or trached for a long time, so weaning may be difficult ultimately. There's a lot of products to make weaning easier, like we can put the heated high flows and all those things on there. That helps them out. Weaning and decannulation. Underlying condition is resolved. They don't need the trach as much anymore. We can downsize to a smaller trach, downsize to a cuffless. We can do cuff deflation trials to make sure they're protecting their airway, especially if they're a stroke victim. We can put trach caps or buttons on them, or if they're fenestrated, that's more historical, then that's something that we can look at too. So usually we'll downsize, and if we get to like a 6 or a 6.5 or a 4 or 4.5, then we would go ahead and pull or decay if they didn't need it. Fenestrations, that's what you're looking at, all these holes on the back of the trach tube here, or just large holes there. They can develop a lot of granulomas. That's what you're looking at here. But they were an old way of doing allowing the person to speak, because then gas could escape, go through the vocal cords, and then in theory they could speak out of there. So we stopped having this because there was a lot of issues with granulomas. So I was not a big fan of fenestrated trachs, and that was a big whole thing. So they have two intercannula versions. They have an intercannula that has the hole in it. So let's say they're using it to speak, then they would use the one with the hole in it. If they weren't using it to speak, they were just using mechanical ventilation, then they have the complete one, which did not have the hole in it. Kinstner tube, I will test you on this. This is a placeholder. You will rarely see this. So you put this in the stoma and it holds the stoma. So just keeping the stoma open and patent, it's a placeholder. So let's say this person needs to wear a vent at night, and having a trach in their airway throughout the whole day is something that causes too much air resistance, or they can't do their activities of daily living with it in there. So they might actually be able to do this tube during the day and then place a trach at night and be connected to a ventilator at night or whatever it is, and then just have a placeholder during the day. So my whole career, I had never seen one of these. Doesn't mean it's not out there. That's just anecdotal, right? Because that's just me in my experience. But so it just sort of placeholds that stoma, keeps the stoma intact, and then that way, if we need to put a trach back in, it can be done. Decannulation, so that we're getting rid of it altogether. You could either go down to a fenestrated trach where they're using their upper airway. You could downsize altogether, using it smaller. You could start putting trach buttons. As long as it's a small size tube, you should be good there. Once you've taken the trach out altogether, you need to assess the patient, make sure their oxygen requirements aren't increasing, make sure x-rays aren't increasing, make sure they're not starting to run new temps now, right? Like they developed an aspiration pneumonia. They have good strong cough, right? They're not developing an infection like a pneumonia. When we pull it all out, we're going to cover the stoma with sterile gauze. Usually, each hospital has its own policy there, but we do not suture the stoma closed, or it'll close naturally in a couple of days to a couple of weeks, depending on their nutrition and their overall health. Depends how fast it'll close. It also depends if it's an open trach, like a surgical trach, versus a perc trach, right? So an open trach is going to take a lot longer, and usually those are for your permanent patients anyway, but a perc trach, not nearly as much. Decannulation, please watch these videos. Do not try to swim with the trach in. That would not be good. Airway emergencies with these trach tubes. Signs and symptoms: respiratory distress, they're having trouble breathing. You don't see good chest rise, but you see abdominal moving. but no chest wall movement. That's a sign there's an occlusion in there, right? Like this, what you see here, this giant mucus plug on this person in the top right photo here. Air movement around the mouth and the tube. You see changes in the vent pressures where they're using high pressure, high peak inspiratory pressure. You need to start acclimatizing to these terms before you get to mechanical ventilation. So high peak inspiratory pressure if they're on volume ventilation, or low tidal volumes if they're on pressure ventilation. So if you see either of those, then that's a sign of an occluded tube, or one of your signs of an occluded tube. Most common airway emergency would be the occlusion with these, right? Not enough heat, humidification, so on and so forth. Hopefully it's just the inner cannula, right? We could remove the inner cannula, switch it out with a fresh one, and you're good to go, right? The airway is compromised. If let's say it's a Bavona, you might have to decannulate all together and then put in a new trach, and shame on you if you don't have one the same size at the bedside. And once again, shame on you that you didn't have one at the same size at the bedside if there wasn't one. Is this an emergency, right? This is where it pops off here. Yeah, this can be because you're losing volumes, especially if this person's connected to a mechanical ventilator, right? Drawing. It looks like a tree. Great. My Bob Ross days are over. All right, so is this an emergency? Yeah, absolutely. So it's coming off. They're not getting their pressures. They're not getting their volumes. They're hypoventilating. They're retaining CO2. They're losing oxygen. They're more prone to getting atelectasis, which means they're more prone to having or developing a pneumonia. So this is it's a bad situation. So all we need to do here is just push the inner cannula back in, right? That's all we need to do, but that's something that we'll look at.